People started like 20 minutes late on committee meetings, so. Just waiting for it to redirect.
What meeting was that? Is it just you and me on this call right now?
Yeah, it's just us.
What meeting was that the other night that went on?
PA. I sent you the link now, Tracy.
Clinical lab the other night?
No, it was the physician assistant was the other night. It went
I was like, I was ready to hang up. It's like nobody wanted to answer.
It was a long time.
That was the worst meeting I've ever been on. It's like nobody wanted to participate, but everybody was on the meeting.
I sent you the link.
Yeah.
I know what you're saying.
You know what I mean? It was crazy.
I'm sorry. I'm trying to get myself ducks in a row. Why do I have it?
Okay, it is up.
All right. Oh, here we go. People are coming back.
Okay, I think we've made the transition. Everybody's here. Ms. Darby, you can begin the meeting, and we are monitoring the emails for any public comment.
Okay, thank you. The meeting of the Louisiana State Board of Medical Examiners Occupational Therapy Advisory Committee pursuant to lawful notice is duly convened and called to order at 10:03 Friday, February 10th, 2023 via Zoom virtual video. Please note any comments by the public are welcome and can be emailed to publiccomment@lsbme.la.gov. Dr. Van, please confirm that you have verified the identity of all tele and video conference participants.
Yes, ma'am, we have.
Okay. All additions to the executive or public agenda must be made presently, as we will no longer make additions to the agenda after the close of the public session. Just going to quickly review the mission of the OT Advisory Committee is ultimately to protect the public, that is the consumers of occupational therapy, by regulating competent practice and upholding the standards set forth by the governing rules and regulations. Members present today are myself, Darby Philibert, Chair, Ingrid Frank, Vice Chair, Brenda Martin, Kelly Brandon. We have Carolyn Murphy is absent, Raylena Crooks, Kimberly Solari has not yet joined us. Amy why can I not do your last name? Say it for me again.
Lara Riviere.
La Riviere, okay. I'm sorry, and Glenn Wallace is absent. We also have Dr. Vincent Collada, who is the LSBME Executive Director. Olivia Pilong, the Executive Program Specialist. I don't see Patricia Wilton. Is that correct?
She will be joining us. She is actually filing some papers at the state office for an emergency rule, and she will be joining us as soon as she can get back. And we have Ms. Johnson, who is the Director of Licensing for OTAC.
Okay. And we also have Tracy Morrow today, who is in IT. Do we have any other guests that I'm not seeing in the minutes? Okay. So Ingrid, can you please confirm that we have a quorum?
Yes, we do have a quorum.
Okay, thank you. All right, so we're going to move on to the approval of the minutes from the meeting on January 13th, 2023. People can review those and suggest any edits or changes. And if not, I would need a motion to accept the minutes as written that were submitted from Ingrid Frank.
I didn't see anything that needed fixing when I looked at them, so I move to accept.
Thank you, Brenda. Someone like to second?
I'll second, Ms. Raylina.
Thank you, Raylina. Okay, all in favor, please say aye.
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 Anyone opposed or abstain? Great, so the minutes will be approved as written. Thanks again, Ingrid, for getting those out. Let's see. Next agenda item.
Next agenda item that I have on the agenda is your rules and regulations work.
Okay, is there, I'm trying to find the original or the one that was.
This is what you sent us.
Okay, I have the practitioner question response update next. As number 2.
Would the agenda be above the minutes?
It's I did not see anything on the agenda that had anything else about the letters.
Okay.
Okay.
There
I
it
have the
is.
one that Olivia.
Okay, I'm sorry.
sent
Do
in.
you mean this? I apologize. This right here. Okay.
Yes, so the practitioner question response update is, it's actually just a question more for you, Dr. Van, just to try to get the update regarding the 3 questions that were submitted by the practitioners that Ingrid and I have submitted the responses to.
Right.
With the link to prescription, just to see if those were actually responded to the practitioners.
Well, we thought you all would be doing that because you said you wanted to send emails from you all. We tried again. My understanding was we suggested that you do it by voice, and you said no. We want to do it by email, and that's fine. Just make sure you put the disclaimer in it that you are not speaking for the board. This is the best advice you can give, and if somebody wants an official board opinion, they have to request it of me to do it, and we'll get it on the agenda. But again, I think the key is that's why I said it's probably better for you to talk with them in person. But again, you want to do it by email, so you can send emails out on yourself. We're not sending them out for you. You all are sending them out with our advice.
Okay, I'm sorry, I misunderstood because I thought that Patricia was going to review them just to make sure that the response was congruent, and then we will send them out. So Ingrid and I are going to send those
Okay.
out.
When Patricia comes on, we'll see if she's reviewed them. I thought she had, and y'all were sending them out. It's my mistake to follow up on it, and she'll be here in a few minutes, I'm sure.
Okay, yeah, I have no problem emailing them. I just wanted, y'all to look at them just to make sure the wording was congruent with what, it felt like it needed to be, and there was nothing ambiguous.
Okay.
And we'll check with Patricia when she jumps on. I'll just put a note here to loop back around that agenda item, if that's okay.
It's fine.
Okay, so we can move into the rules and regs update, or we can quickly do the new business.
I just have one quick old business, which is that we did get an email from Susie Allen recently about the rules course, and she is wrapping up updating the rules course and creating the quiz, and she's going to be sending the quiz, or she's going to be opening up the quiz to Darby and I to take for practice and to give feedback, and then we can also open it up to the other OTAC members for feedback, but she wanted to start with just Darby and I. I don't have a date on that, but that's the update on the rules course.
Thank you. Yeah, and then obviously, just so that y'all know, when we discuss that, we will be opening into an executive session to discuss those after the committee has a chance to look at or take the quiz. Then we will open up an executive session to discuss it.
And just to be clear, for anybody who's watching, the reason is it will actually be discussing the quiz questions. And we can't let the answers out to the quiz questions. That's why we will do it in executive session.
Thank you for that clarification. Yep.
And Ms. Wilton is joining us right now, and we can talk about that. I just admitted her, so she should be in any second.
Okay.
I am here. Thank you. Thank you.
Hello,
hit-
good morning.
Hi.
Darby had a question and I couldn't answer it, so maybe let Darby ask that question right now.
Okay.
So on the agenda is a request for an update regarding the practitioner questions. So the last thing that had happened was after the last meeting, Ingrid and I sent to you and Dr. Van our responses to those practitioner questions with the clarifying statement of sort of, that this is not like legal,
Right.
with the statement that we agreed on. So
Yes.
I was under the impression that y'all were going to sort of okay it or give us the stamp of approval before we sent that response out to the practitioners. I didn't know if you had a chance to look at it, if you felt like it was okay, or you felt like you were waiting to revise it.
No, I remember looking at it. I don't remember having any problems with it. And I dropped the ball on like closing the loop on that, saying it was good to go. I think I had forgotten that y'all had made the decision at that time to finalize the actual process that we would approve, we would say, yes, this is great. And then y'all would send it out. So that one is fine. I think was there just one or more than one? I can't remember, but yes, I did review those and those were fine.
Yeah, there were three. One was about the length of a prescription and how long
Yep.
it lasted. One
Yep.
was about the out-of-state MD referral, and one was about the reevaluation timeframe.
Yes, and it was all the actual points and responses that we had all agreed on, and all you were doing was just sticking the disclaimer on it. Isn't that right?
Correct.
Yeah. No, those are fine.
Okay, so I'll be sure to disseminate those responses to the practitioners. I'll try to get that done by the end of the day today. So, okay, perfect. Thank you, Patricia. So we can check those off and that is done. So just in the, so that we have time to do the rules until the end time, I'm gonna skip, if y'all are okay with it, to the new business and just give y'all a quick update on the state regulatory meeting. So that was, I sent the link out to the committee to invite them to attend. I know I saw Caroline Murphy on there for a while. I'm not sure if she stayed the entire time. That was on January 25th. Ingrid and I both attended the virtual meeting. It was a presentation by Becky Finney, who is the Ohio OT Association president, and Camille Subik-Poplasky, who is currently on the Kentucky board and a former association president. So her and I actually had a lot in common, but they gave this, it was basically a PowerPoint presentation that we can get access to that basically delineated the differences between the OT Association and the regulatory boards. So I felt like, some of the slide presentations was just basic explanations of rules that might be a really good introductory part for anyone who's new to the OTAC committee. It might be something that we want to consider reviewing with them before they come on, so that they, I guess those of you who are newer to the board, how we can make the transition better onto the board. But two things that came up that sort of stuck, Ingrid and I talked briefly after the meeting about it, so there might be more, but these two things were the things that kind of stuck out. So one was that it seems to be a standard of practice and recommended that the rules and regs of the states be updated every 5 years. And so, that sort of sparked interest since we're in the process, but we don't have anything currently in our rules that state that they should be updated. But I think if we determine how often, we can all agree if it's 3 years, 5 years. That way, this laborious process of going through the entire thing wouldn't really need to be done. That we just update it, every now and then. Another thing that they talked about was the OT compact, which is no, big news to us. And that, it's really being pushed more by the military in many states, and more states are joining. We know that that's not our decision, but something that we need to stay aware of, especially in adopting the rules and regs. Another interesting thing was that many states are now having jurisprudence exams. So again, we're sort of, in the process of doing that for our state. So I felt really good about that. And then the only other thing was that they stated that the advisory committee often presents, or in many states yearly presents, in conjunction with the OT state association, for just more communication given the practitioners' updates. And ironically, directly after the meeting, I got a message from Jennifer from the Louisiana OT Association, who's the president, asking if we could do this. Dr. Mann, I see that you have your hand up.
Yeah, just so, we get consistency across the language. We've been directed at the board level that jurisprudence is not for us. It is law and rules, and
Right.
it's jurisprudence is really, we were told by the judges that served on the board at the time, and the board approved that. So we call it law and rules courses. We don't call it jurisprudence.
Thank you. Yeah, the way they presented it, they referred to it as jurisprudence, but I know that we've changed it to laws and rules. But it just made me feel better that, like, we were actually doing something that a lot of the other states are also starting to do. So, it was just sort of like a confidence in our committee that, like, we're keeping up with what the other states are looking into and starting to do. And I feel like we were possibly one step ahead. So that was really nice. So does anybody have any questions about that forum that happened?
Wait, can you continue what you were saying about getting a call from Jennifer?
Yeah, Jennifer just asked if I was open to some collaboration, and she was going to look into seeing if there was time at, like, one of their conferences. She was going to get back to me. I told her that we were happy to update them. I, reminded her that all of our meetings are live streamed and you can go back and witness, but she just felt like the presence of a member of OTAC at the state association conferences may be a good thing for the practitioners in the state. So we didn't, I didn't agree to, I just told her, yes, that we're open to discussion. So I haven't agreed to do anything, or she was going to get back to me on that. Okay. So that's about all for the new business. Are we ready to go into the rules and regs? Dr. Van, can you just check to make sure we don't have any public comments regarding the new business before we move on?
Yes, ma'am. 1 second. No, ma'am, we do not have any public comment at this time.
Okay. So if everybody can pull up their rules and regs. So just remember, the red stuff will be things that Ingrid and I have looked at and tried to make suggestions. Any highlights would need more information, and the green would be things that we've already adopted.
Darby, I would need the screen sharing capability so I can pull up the one that I can actually type on.
Okay, no problem. Let me get out of that, stop share. And let me see what I can do to give you that authority.
Miss Ingrid, I made you co-host. You can share now.
Okay, great.
Thank you.
Okay, is it up for everyone to see? Can you see it, Darby?
No, we see your,
Your meeting, your folders.
That's what you're saying? Okay. Let's see.
there we go.
I
That's
see,
it.
okay. I have two screens, so I can get them
Yeah.
confused.
Me too. So I'm always like bouncing between them both, and
So I love my two screens though. Whew. Don't take them away from me. All right, moving down to where we were.
yeah, the last section, I think that we had, we were on subchapter B, standards of practice. 4905 was just the scope of chapter, 4907 was the screening, 4909 was referral. And I think that we are on section 4911 evaluation, according to my record.
Correct. And then in the course of Darby and I starting to look at a few other states' rules, we came across some things that we just sort of threw in there because we want to remember to add them at some point. And that's why I have all of this that's in bright green. Here, what we just threw this in here, this was based on the course we just took from AOTA with the rules governing occupational therapy in Louisiana should be reviewed and updated every blank years, you know, if we want to include that. We saw that another state has specific language about using the term doctor now that more and more OTs are going to be graduating with an entry-level doctorate, and when it's appropriate to use that term or not. So we thought that would be something we want to discuss. Other states have specific language about licensing a foreign trained therapist that might be just maybe more clarifying than what we have. That was Kentucky. Kentucky also has specific language on supervision of OT aides and students. We do not currently have that. Something to think about. This is probably Alabama's aides in right here.
I think
Yeah.
the Kentucky part was the students.
Yeah, I think we had Kentucky, both aides and, yeah, we have aides, Kentucky, students, Kentucky, and then this part is aides as written by Alabama. So just I just put it in there so we wouldn't forget, because Darby and I both thought that those were areas that our current rules don't address these things. Well, they do address the foreign trained therapists, but in case we wanted to make that clear. But we don't have any specifics on addressing supervision of students and aides. And I do think it's an area that OTs in Louisiana struggle with, so we may want to consider it when we get to that appropriate point.
And I
Okay,
think one of the states, didn't they address like the billing of those? So that was something that we were,
billing, do we have, I don't recall. I don't think I added it in. We have to go
okay.
I don't know. I don't want to start talking about billing in our rules.
Yeah.
All right. So yeah, we are up to looking at evaluation. And Darby and I have struggled with this and how much to change and to add in versus from like scope of practice and things like that. I feel like this is a little bit messy. Actually, we had done evaluation, Darby, because that's all green. We were up to, we did that last time. We're up to 4913.
On that intervention process. Okay.
Yeah, that's where we're at.
So I think the thing that, like Ingrid was mentioning, that we struggled a little bit is it's currently written sort of like in lists, and whether we keep it like listed, which my brain tends to be a listing, like bullet numbered, versus, you know, more like a paragraph form. So we kind of went back and forth with that with some of it. And then just to back up, because I know we didn't talk about this, but Dr. Van and I were discussing this a little bit before the meeting, is I'd sent y'all the copy of the Model Occupational Therapy Practice Act. So again, that's just a practice act. It's not the rules and regs, but it did have some language that I thought was very interesting, and to look at like similar topics to use it as another reference, like the standard of practice. So, hopefully y'all all were able to get that and look at that just briefly, but some of it does overlap. So, you know, we can also refer to that as another document. All right, so Ingrid, you want to take over or you want me to?
You go ahead.
Okay,
Okay.
so we're gonna start at 4913, individual program planning. We felt like this section was really more of the intervention process. So the section before is evaluation, and then this section would be the intervention process, which would move to the next section, which is implementation. So that was just semantic and updated verbiage change. You know, so again, we're open to that if y'all want to discuss that. So you can see almost like right next to it is what we struck through. So we struck through the listing of things, and we used more language from the standards of practice. So we have an occupational therapist has the overall responsibility for the development, documentation, implementation, modification, and review of the intervention plan. When delegating aspects of the occupational therapy intervention process to the occupational therapy assistant, the occupational therapist is responsible for providing appropriate supervision. And we highlighted the word appropriate because we felt like we wanted to talk to Ms. Wilson about that, just because we felt like it was an ambiguous term. We weren't sure if we wanted to include words like that in this. But, you know, just kind of looking at that as to, that's sort of the overall responsibility. Then B stated that the intervention plan development shall be based on the evaluation of client goals, the best available evidence, professional and clinical reasoning, and client outcomes. C would be the intervention plan should include relevant measurable client goals and related timeframes, frequency and duration of service, and types of interventions. D would be that an occupational therapist ensures that the intervention plan and any modifications to the plan are documented within the timeframes, formats, and standards established by the practice settings, agencies, external accreditation programs, state and federal laws, and other regulatory and payer requirements. E, an occupational therapy practitioner collaborates with the client to develop and implement the intervention plan based on the client's needs and priorities, and informs the clients of potential benefits and harms of the intervention. And then we added here, I guess that's supposed to be F, the intervention plan modification would be that the OT practitioner selects, implements, and makes modifications to interventions consistent with demonstrated competence levels and client goals. All interventions are used to facilitate engagement in occupation. G, an occupational therapist modifies the intervention plan throughout the intervention process and documents changes in the client's needs, goals, and performance. H, an occupational therapy assistant contributes to the modification of the intervention plan by ongoing communication and providing documentation about the client's responses to the intervention. So basically we try to start with like the overall like process of developing it. And then we talk about like what should be included when you develop the plan. And then we started talking really about the implementation of the plan, and then we moved on to the modification to also include the role of the assistant in the modification. So that was sort of the line of thinking with the organization of this section.
I don't recall why we struck through I about documenting it. Does that come, is it because it comes later under implementation?
Think so, but we also mentioned something Yeah, I think that was more in the we felt like that was going to be, but we didn't get to that part. So yeah, I know. I see the word promptly also highlighted. I'm not sure.
I know we had it and then we crossed out.
Maybe we don't need to cross it out, but
We need to talk about documenting.
you know, we're trying to be mindful of the wording, like appropriate. Like I know you remember us talking about that last time because it was in another section, and Patricia was like, let's not use that word, which I agree with, but unless we define it clearly.
It looks like our previous language right here, number C, I turned it gray. The initial program plan shall be prepared and documented promptly. So we did address documentation before. I don't know why I've got it crossed out.
Yeah, I don't know if that was purposeful or not.
Maybe you just had it crossed out because that promptly does get really vague, and it
Yeah.
does. You do mention documentation prior.
Did I? Did we? Good.
Well, it's like it's in the list of document changes,
Oh, yeah,
provide
and
documentation.
Yeah, how all, different regulators, insurers, facilities have their guidelines on what is considered timely documentation. I don't know what exactly our role is in if we establish something like that for public safety, from looking at it from a public safety perspective. Certainly an OTA cannot treat until it's been documented, but that's talked about later in the OTA supervision section.
Yeah, I think we took it out because we have that in D, and we didn't want to be ambiguous about it, but we also don't want to like,
Oh, that's it. Right. It's right there
like
under.
how many questions like come up, like, do you have to document every session versus like if you see it multiple times, like a summary? But we're gonna, leave that up to the standards established by your either facility, your program,
Yes, I forgot about letter D.
Yeah. So I think it was because we
That's what
included D. Try not to be repetitive as hard as it is. So any thoughts or comments on the intervention process? We tried to make sure that everything we crossed out was actually like addressed.
I like the way it's laid out. I think it makes it easier to, like, I think it makes it clearer.
Yeah, I mean, we try to like organize it like how it happens, like after the evaluation. But just because we think it's clear doesn't mean it is. So
Right.
just took a couple of hours, and the goal was to save us from that pain. And then I guess I'm gonna ask Patricia what your thoughts are on section A with using the word appropriate supervision. Can we leave that word? Should we replace it with something else? Or do you think if we leave it, we need to define it?
I think appropriate is undefined, but at the same time, there has to be some recognition, I would say, that appropriate's going to vary, I would assume, from patient to patient. So the solution, one possible solution, is to add a whole bunch more words, which I'm loath to do. Appropriate, pursuant to standards of practice, blah 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 blah. So in this case, I guess I'm okay with appropriate in the context of the entire Practice Act and standards and guidelines for occupational therapy in general.
You know what I'm just realizing? that, you know, later, we're going to be having specific rules about OT assistant supervision. So could we just say here, responsible for providing supervision as stated or outlined in section XYZ?
Yes.
What do you-
Okay, I think that'd be better. Don't you all? Instead of, that way it gives them a section to, like, if they're looking at it, to reference.
I don't know what the name of the section is right now,
Um,
but we're going to be getting to it at some point.
it's supervision of occupational therapy assistants. Right now, it's section 4925.
Okay.
But you may want to highlight it just so we can make sure at some point that we check that. And that is exactly where we're putting everything.
Any other changes anybody see, or?
So the other thing, if you notice, like sometimes we mention like an occupational therapist. And then like an E, it's the OT practitioner. So that means it would include the therapist and the assistant. So just kind of to make sure in y'all's minds, like that sort of stands out and is clear. And Ingrid, I guess my question, the purple between E and F, was that part of the reference or is that a different section?
No,
Or was
I
that just the beginning of
think
F?
trying to create.
'Cause B, you have purple.
Why did I put that in purple too?
I think it's supposed to start F.
So intervention, like, do I make this a sentence, like intervention plan modification in, let's see, do we need that word intervention plan modification at all? Because F basically talks about modifying it.
I mean, you can start with, if you want to put it like for intervention plan modifications, the OTP select. I mean, I think it helps with the organization, but if y'all think it's too wordy, then, you know, I'm fine taking it out, but.
When modifying the intervention plan, let's see. Somehow grammatically, this is bothering me.
Do y'all think it's that this like includes the roles of the assistant clearly? For like the plan modification and.
I like the use of the OTP. That's helpful.
Okay,
Yeah.
It feels like this should just be intervention plan modification, like capitalized, and then I don't know, grammatically that's not working.
Yeah, it's right, but I'm with you, Ingrid, it just doesn't flow correctly. But I don't know how to fix it.
when modifying the intervention plan, blah, blah, blah.
When modifying the intervention plan, the OTP, yeah, that would work. When modifying the intervention plan, the OTP selects, implements, and makes modifications consistent with.
Demonstrated service competency. I don't know.
And demonstrated competence levels, that is in reference to
Service. Yeah.
the fact that the OT and the OTA both should only select interventions that they're competent with, that they've demonstrated competence with. It's not necessarily just of the OTA and the competence. What did you just call again, Kelly?
Just service competency.
Yeah, service competencies.
But
Which
which part do you not like? The beginning?
OTA, but we mean it for both here, you know?
Yeah.
Yeah, she's struggling with the very beginning and how to incorporate the intervention plan modifications. So it's basically saying like the OT modifies the plan and then the assistant can contribute to it with
Well, no.
ongoing communication.
The OT, it's when modifying the intervention plan, the OTP can modify the intervention plan. The OTA can change what interventions are being used.
I mean, I kind of went on to G because like, this is saying like implements and makes modifications consistent. And then G says that OT modifies the plan throughout the process.
Okay, so it's kind of unclear, do you think?
Well, it's just, I don't know if it's saying sort of the same thing or if the point of G is really just that it's ongoing.
Mm-hmm.
Or that's more like documenting the changes in the like needs, goals. I wonder if we need to include the word priorities. I'm not sure, like.
It seems to me that if you, pardon me the interruption, but it seems to me that you have B is the intervention plan development. And then it almost looks as though C and D could be 1 and 2 under B. And then you could do C, intervention plan modification, and then have, F and G be 1 and 2 under that.
Cool.
Yeah, I think that might be better. Thank you.
I'll figure out how to indent it later. Okay. Wait, is C?
Yeah, I think C would be 3.
3.
Yeah.
Okay.
And then D would start, I mean.
C is modifying the plan.
Right.
Yeah, so you might put the title back, like how B has intervention plan development, then you could put C intervention plan modification, and then
Start a sentence.
yeah.
Mm-hmm.
We could.
Kind of how you had it, intervention plan modification.
Yeah, and we could even, to make it consistent, do it like that. I don't know why this is purple. So it would be the same. B is intervention plan plan development,
Okay.
C is intervention plan
Modification.
So this C is about actually just making modifications to the interventions themselves, which can involve either the OT or OTA. Whereas D, it feels a little bit more global. It almost feels like that one should go first.
Yeah, that makes sense.
Yeah, I agree with that too, Ingrid.
You see what happens. Throughout the intervention process, documents the changes. Okay, and then D, when modifying the OTP, then E, an OTA contributes to modification of the plan by ongoing communication and providing documentation about the client's responses to the intervention.
So D and E would be 1 and 2 under C.
Yep.
Okay.
And then y'all are okay with like what is on the screen is D, that we take that out because we feel like we covered it in D.
We
That's
covered
what
it.
I'm thinking.
So like if we get a practitioner question saying like, do I have to do documentation for every session that I see the client, or can I just do a weekly summary? Do we feel like it's answered in here?
The answer is here in number 2, B2. But yeah, asking, do y'all feel it would be answered?
Like we would just say it really goes back to your practice setting, or your payer requirements.
I think that would cover it.
Okay. And then I guess I'm just gonna play devil's advocate. And what if it's sort of like a private pay situation? What's the ethical obligation for documentation?
May I interrupt a bit?
Of course.
In the world of billing, particularly Medicaid, Medicare, the documentation must be sufficient to justify the charge. And most insurance companies adopt that as well. So again, I think that if you were going to be talking about getting paid by the government agencies, you should say, well, you reflect that it's their regulation, but probably it needs to be documentation sufficient to justify the services rendered. And that way, if it gets to a medical legal arena, Pat can comment on this, what is the court's going to expect you to do should it be a medical malpractice issue? So maybe Pat will comment on that as well.
I mean, yeah, it doesn't hurt to incorporate within the rules the concept that they do have to follow the appropriate billing guidelines and under state and federal law. So, obviously that overshadows everything throughout the document, but for this specifically, it's probably a good idea to use language similar to what Dr. Collada suggested.
Can you repeat what you said about what you said, Dr. Collada?
Sufficient to justify the services rendered.
So maybe we just include that, yeah, in there, because
Let me see if I've got it correct, Nancy. State and other regulatory and payer requirements sufficient to justify the services rendered. Is it a complete sentence? It's a long one.
It's a run-on sentence, but it's okay. William Faulkner made a fortune off of them, so don't worry.
I mean, do you feel like we need to list it out? Is it too much?
I like it.
And I like including everything, and I love the ending there because I feel like it doesn't leave anything to where somebody says, well, they pay me privately. I don't have to document, which has occurred in the practice settings. Okay. Let's see. Yeah, so previously we just had that statement about prepared, documented promptly, like we didn't really have. Okay.
Darby, I have a question about in B, where it says client outcomes. I've read that like 6 times and it still doesn't. Should it be like client desired outcomes? Like, since it's just the planning, or am I just like reading it wrong?
Wait, and B. Okay, I couldn't tell if you said B or D. So I was
Oh, I'm
looking.
sorry, B.
Based on evaluation, client goals, best available evidence, professional and clinical reasoning, and client outcomes. It seems like it doesn't belong, because if you're just doing the plan, you wouldn't have an outcome. Right? Is that what you're questioning?
I guess that's what caught me as I was reading it, and Might just be my weird brain. It might be fine, but just wanted to throw it out there.
I do like that it includes outcomes because you consider that in the plan. So maybe if it said client identified outcomes,
Or priorities, is that really what we're, because if the client, like, are you saying like the client goals, like what their,
Right.
I mean,
How is
we're-
outcomes different from goals?
yeah, so like it's,
The client goals are what, like the client tells you, I actually just finished teaching the OT practice framework 15 minutes ago. So we
Yeah.
just went over this. So the client goals will not be written in measurable terms. Like the client usually tell you something like, I want to be able to stand at my work desk without lower back pain for the majority of my workday or whatever like that. It's just some sort of vague goal. And then the outcome is the actual measurable goals that an OT would write based on the client's goals. That's kind of
Right.
how.
So whoever said desired outcomes, that might be.
Well, the client's desired outcomes comes from the term the client's goals. I mean, we may be.
I see what you, yeah.
Or anticipated outcomes.
so let's go back to what's included in our plan. Like in our plan, we include the client goals and the measurable outcomes. Right? When we're doing a plan, like we would include both.
Right.
Because we need those measurable outcomes to say whether or not we're effective and to guide treatment. And so maybe that might be something that, so this is saying that the plan development is based on, and you see we have client goals already in there.
Right.
Evaluation, the client goals, the evidence, clinical and professional reasoning, and maybe it's not the client outcomes, but more of like the measurable outcomes. Or, is this where you were trying to delineate between goals and outcomes, or we're just trying to include them both? Or do we say client goals and outcomes?
Yeah, you could do that, I guess.
Actually, I think that would
Yeah.
make it clear client goals and outcomes.
the OTPF talks about outcomes as like the different areas, like occupational performance, health and wellness, occupational justice, participation. So there is a little bit of a difference there in talking about the client goals, like Ingrid said, and then the general outcomes of the OT intervention to address those different areas. So I think just adding the outcomes to the goals would be good.
Yeah,
Okay.
client goals and outcomes works well because you wouldn't put them in the same sentence if they weren't two different things, and then they're being taught that they're two different things. So that looks better as opposed to looking like we just put two different descriptions of the same thing.
So just for y'all to think in your mind when you're doing an intervention plan, like without looking at this, think of the steps that you go through, think of the things that you include in your documentation, and then reflect on this of like, is there anything we're missing?
Is there a part about, it might be later, referrals or anything like that? Or
We did that in the section before,
like
to
referral
make
to specialists or, okay.
other
I remember
professionals.
talking about it, but
Yeah, I think we talked about that last month at the last meeting of like in the in the
I
screening.
mean, our responsibility to refer to other healthcare practitioners as
Yeah.
needed. Yeah, that we did already cover that in a different section.
I think it was in the screening and the evaluation part. Like I think
Okay.
we put it in both. But never hesitate to ask because you never know.
there was something else.
So we have like what it's based on, then we have what it should include. So then again, we say relevant and measurable client goals and related timeframes, but we don't have outcomes in that number one. Or not number, like the first one under C.
First one under C.
Right. So we have B, like this is the plan development, like when we're developing the plan, we're saying that we need the client goals and outcomes, evidence, and clinical reasoning. And then the next one, B1, says the intervention plan should include relevant and measurable client goals.
Mhm.
So should that say goals, comma, outcomes, and related timeframes?
No, I'm fine with it the way it is. You
But the
this
client goals aren't necessarily measurable, right?
well, the OT is taking what the client's goals are and making them measurable. That's what we're saying they've got to do here, you
Right.
know, which is what everybody does do.
Okay.
Hopefully. One thing, just to point out that Darby and I changed from previous language. The previous language, I'll just highlight it gray over here, stated that you'd had to have both short and long-term goals. And we avoided stating you had to have both and just changed it to relevant and measurable client goals, because it might not be appropriate in every setting to have a short-term goal. I know that's one thing that's come up in acute care before,
Yeah,
is,
that's a
you
good
know,
idea.
Okay, so then from there, 2 talks about the documentation. Then 3 again would be the collaboration during the implementation of the plan. And that's where we really wanted to include the potential benefits and harms of intervention. So that's kind of more like development of the and then C would be the modifications.
well, are we ready to vote on these changes, or anybody have anything else?
Okay. All right, so we need a motion to accept the changes to section 4913 as proposed.
I'll move to accept the proposed changes.
Okay, thank you, Brenda.
Thank you. Second it.
Thank you, Amy. All right. So,
We have to vote, Darby.
yep. I was just looking at something. I'm sorry, I got distracted. All in favor of these changes, say aye.
Aye.
Anyone opposed? Abstain? Okay, Dr. Van, do we have any public comment on section 4913?
No, ma'am.
Okay, thank you. All right, so another one tackled. This is where Ingrid and I, that's where it ended for us. We met, I think, twice in between those last two meetings, and that's as far as we got. So just to sort of recap, we under this, we did the evaluation. Then this part was the intervention process, and then 4915 is now the individual program implementation. So I don't know if there's like a different wording for this section. If this, basically this talks about the implementation of direct OT to individuals for their specific medical condition or condition shall be based on a referral or order from a physician, dentist, podiatrist, optometrist, or advanced practice registered nurse licensed to practice in the state of Louisiana.
Darby, just right off the top of my head, you know, we already clarified that under the referral section.
Correct.
So this is the kind of thing I think we ought to get rid of redundancies.
Yeah, no, I agree. I didn't know if we wanted to like just read through the 5 things and see if it's all redundant. Definitely A, for sure. It will kind of keep that in mind. B, occupational therapist shall implement the program according to the program plan. Occupational therapy assistants may assist in program implementation under the supervision of and in consult with. Again, I feel like that's unless 49, I think 4919 and 4925 are about supervision, but we basically talked about both of those earlier. C is that the OT shall formulate and implement program modifications with changes in the occupational performance and performance skills. D is that we periodically reevaluate and document the client's occupational performance and performance skills. And E is that we promptly document the OT services provided and the frequency. I mean, I feel like all of those we've touched on in the intervention process part.
The only one that we didn't is D.
Yeah.
Because currently, periodically, as currently defined in our rules, means every 2 weeks or 6th visit, whichever comes first.
Yeah.
So our currently rules basically say OTs have to reevaluate the client's occupational performance and performance skills every 2 weeks or 6th visit, whichever comes first. And so we have to, I think we do need to decide whether we keep specific recommendation like that for public safety. Do we need to be clear on how often we're expecting an OT to reflect on and reassess whether their implementation of the program is working or not?
And wasn't
Yes.
this the questions recently?
Yes.
It was, exactly, because everyone always seems to think that the only reason you have to reevaluate every 6th visit is when you have a CODA working with you. But we've got it right here. This has got nothing to do with the CODAs. And we're saying that then an OT has to reevaluate the services being provided every 2 weeks or 6th visit. And personally, I kind of like it, but it's something we need to all think about.
And I mean, I feel like, and Ingrid and I have talked about this, is like, I'm not sure that I'm comfortable really saying like every 2 weeks or every 6th visit, but I feel like it should be more based on the client's response to intervention and their performance skills and their outcomes. So for instance, like some clients don't make a whole lot of progress, you know, and then you sort of slip into like a prevention mode or things, and that does change the course of the intervention. But, you know, for some clients, reevaluating every 2 weeks or every 6th visit is sort of overkill. But then for some, like more acute, it's like you need to do it more often. I feel like, you know, this is something that we have to really consider, like all types of clients, all, you know, school system, everything, when we're really saying like the frequency.
I agree with that, Darby. That was the question I had in in many settings, that would be the exact frequency you would want, but in other settings that may not be the best course of action.
I
Yeah.
agree.
I mean, it's very different if you're seeing a client like 3 times a week versus once a week. You know, like it goes back and forth to where I feel like that, you know, especially when we're not talking about associated with an assistant, you know.
And, you know, under intervention plan modification number C, we are setting up the expectation that an OT will modify the plan throughout the process.
Mhm. Right. So
everything we just said is kind of already covered. Everything in 4915 is already covered in 4913.
do we need to just say somewhere in 4913 something about like when like do we need to mention a reevaluation or reassessment? Like, I mean, that's the next section, but the next section I think deals mostly with discontinuation of services. But like, I feel like if we take this section out somewhere in 4913, we need to mention a reval.
I guess, yeah, not everybody needs a reeval either.
Right, okay, so I mean, that's a good point too. So I'm just making sure that we don't just like wipe it out and then like kick ourselves later that.
Well, right, we have to make sure that we've got enough to where if a practitioner is just coasting and is never really looking back at whether what they're doing is working and every note is the same, that this language that we have is going to be able to help us step in and say, well, you are not modifying your plan. We don't see any evidence that you modified your plan throughout the intervention process. And, you know, just do we have it strong enough? I think we do. I'm just throwing that out there.
Well, and I think some of it gets back to where we added the sufficient justification of services, right? So that's sort of where we're covering ourselves with that. So like in your scenario that you're going, like you're doing the same thing over and over for weeks, months, and maybe even years, then it get back to justifying the services rendered. And is that documented or assessed or in the plan? Because it, you know, because then it could be sort of like a prevention mode, you know, but is that part of the plan? I mean, is that what you're thinking?
Oh, no, I was just more thinking about when people just practically copy and paste the same note every day, every time.
Oh, yeah. Well, yeah, we've got
Really
that
stop
too.
and reflect and.
Well, that happens a lot with all the medical records. I mean, the electronic medical records, like. So I guess for everyone here, just to really think about the setting that you're in or the patients that you're seeing, like, what is the role of the reval, the reassess? Is it needed? Is, you know, does this cover it with this modification plan? And then given the practitioner question that just came up with the reassessment, if we get a reassessment or a reval cover question, do we feel like referring to say like, what do we make it now? Number B2 would cover us and give us a justifiable answer for that practitioner?
I feel like it does. And thank you for the scroll just now, because I was wondering what was the title of the section before. And I think that the title then does cover both the plan and the implementation.
Yeah, and that's kind of why we changed it for, it's just the whole process.
Practice, yeah, they call it the process.
So then that would mean that we're all okay with taking out the section 4915.
I am.
I'm just feeling, for me, I love Dr. Van's sufficient to justify services rendered. I'm just relooking at intervention plan modification. The OT modifies the plan throughout the intervention process and documents changes in the goals and stuff. And I just want to, I guess, make sure that that it's clear that we expect an OT if their intervention is not making the difference that they're expecting, that they're changing it. So based on, I guess, that they're modifying the plan based on the client's response to it. Do we have that somewhere already?
So we have that that we modify it throughout the intervention process and document changes in the client's needs, goals, and performance.
Yeah.
Do we need to say like in a timely manner or not necessarily?
Or in response to the client's or
I mean,
Awesome.
what we're taking out says based on the occupational performance and performance skills. That's listed in every single one of the section we're taking out. So do you want to put?
I like the words you were trying to go after there, Ingrid, about in response to the client's performance or like something.
Yeah, so in H, it brings in the assistant and saying ongoing communication and providing documentation about the client's response to intervention.
wait, where do we have that already?
Wait, I didn't, mine's bigger, so scroll up a little bit. It starts with the assistant right there, number 2. So number 2. So we changed the wording a little bit. So that with the assistant is based on the response to intervention. Like, do you want to put something like that in one?
Yeah,
Yes.
that is what I'm trying to do.
Okay. So clients' goals and performance based on the response to intervention.
There's a section in the OTPF about intervention review.
Mhm.
And it just, as a statement, intervention review is the continuous process of reevaluating and reviewing the intervention plan, the effectiveness of its delivery, and progress toward outcomes. But it uses the word continuous. I don't know if that would be confusing, but
It also mentions the word progress, and I think we don't have anything with that word.
Effectiveness, what was that statement about effectiveness?
says the intervention review is a continuous process of reevaluating and reviewing the intervention plan, the effectiveness of its delivery, and progress toward outcomes. And then it goes into the steps, and then it says practitioners should review best practices for using process indicators and as appropriate, modify the intervention plan and monitor progress using outcome performance measures and outcome tools. So it is an additional step in the process, intervention review. It's intervention plan, intervention implementation, and intervention review. I guess we called it intervention modification.
Well, that was in the OTPF, and we were kind of using more the standards of practice and trying to keep it simple. But I guess I'm trying to get that
What if it
fact
said
in here about effectiveness, that we need to make sure that the OT needs to modify the plan based on how effective it's being.
well, should the intervention plan modification section, that's C, go after the individual program implementation? Because that C could be intervention plan review and modification. an
Mhm.
occupational therapist reviews and modifies the plan. And then it would kind of go in order of I planned it, I implemented it, and I constantly review it and modify it as needed. Does that make sense?
Yeah, no, it does make a lot of sense.
Yeah.
Because you usually review it, well, you can't review it before you implement it.
And you can't modify it until you review it.
Implement it.
An
So-
OT reviews and modifies the intervention plan throughout the intervention process, assessing effectiveness of delivery and documenting changes in clients' needs, goals, and performance. Okay, I'm happier. I don't know about y'all. I wanted something in there about whether the patient's responding or not. This kind of says that to me.
Well, and I like the review part because I feel like we're missing that. Like as a step back and, review it and then modify. So
So
it was implied, but we didn't really say it. So intervention plan review and modification. An occupational therapist reviews and modifies the intervention plan throughout the intervention process, assessing effectiveness of delivery and documenting changes in the client's needs, goals, and performance. Then when modifying the plan, the practitioner selects, implements, makes modifications to interventions consistent with demonstrated confidence levels and client goals. All interventions are used to facilitate engagement in occupation. Occupational therapy assistant contributes to the modification by ongoing communication and providing documentation about the client's response. Better?
Yeah.
Yeah. Teamwork, guys.
Are we
Yeah.
gonna keep it there?
So I'm guessing it's because we had already voted to accept those changes that we have to vote to accept the new changes.
Yep, to section 4913.
Yes. Okay, so I'll motion to accept the changes as now documented for section 4913.
I motion to accept.
Okay. And then all in favor? Please say aye.
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 Anyone opposed? Anyone abstain? Okay. So then that takes us to 4915.
And there's no public comment at this
Oh, I'm
point.
sorry. Thank
That's
you.
okay.
And then 4915 would be, okay, I just want to read through it real quickly just to make sure that we're okay. And then we would need a motion to accept those changes, which would be to take out that section since we integrated it into 4913. Okay, so everybody comfortable with taking out section 4915?
I am.
Yes.
Okay, so can someone motion, please, that we remove that section?
This is Ingrid. I'll motion to remove section 4915.
And Amy will second.
Thank you. All in favor? Aye.
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 Anyone opposed? Anyone abstain? Any public comments on removing section 4915, Dr. Van?
No, ma'am, none at this time.
Thank you. All right, we'll give Ingrid one quick second to catch up. So strike out that section, please.
Oh, shoot.
Love that undo button.
Yeah, I know.
There are occasions when I can't find one and I'm like, I need an undo. Okay, so now that's going to take us to,
We wrote the word reassessment in here, but I don't know that we need to keep that. That
Yeah.
would require more. thought.
yeah. So that was just us. So that's, we can just take that out. I do want to note that right before reassessment, you see that October 15th, like I'm trying to keep track of all these years of like, and I'm wondering if that's the last time revisions were made. You see that?
Yeah, I
Right, so
see.
strike out right ahead of reassessment, like, I mean, that was
Is that
before
that
Brenda and I's
right?
time, but. All right, so 4917, discontinuation of services. This states that the occupational therapist shall discontinue services when the client has reached the goals or has achieved maximal benefit from occupational therapy. The occupational therapist shall document the comparison of the initial and the current state of functional abilities and deficits in occupational performance and performance skills. C, the occupational therapist shall prepare a discharge plan that is consistent with the occupational therapy, client, interdisciplinary team, family, and goals, and the expected prognosis. Consideration should be given to appropriate community resources for referral and environmental factors or barriers that may need modification. D, occupational therapist shall allow sufficient time for the coordination and the effective implementation of the discharge plan. And E, occupational therapist shall document recommendations for follow-up or reevaluation. Initial thoughts, experiences, anything pop out?
Is there any role of the OTA in the discharge process that we're not including here? Because, you know, we wanted to try to delineate the roles as we went.
Not sure. I'm wondering if Kelly Kelly, are you there? I know she's checking on students, but I don't know the answer to that question, Ingrid. I think it's a great question. Does anyone else have any insight?
I'm looking at the standards of practice, and they have that the OT is responsible for determining the outcomes of the intervention, and is responsible for interpreting any outcome measures that were used to decide, you know, that whether progress has been made and goals achieved. But then it says an OTA is responsible for implementing delegated outcome measures and reporting results to the OT. So, you know, if outcome testing needs to be done, then the OTA can be designated to do that. An OT is responsible for documenting the changes in the client's performance and for transitioning the client to another intensity of service or discontinuing it. An OT prepares and implements a safe and effective transition or discontinuation plan. An OTA contributes to the discontinuation plan by providing information and documentation to the OT related to the client's progress on goals. And then an OTP facilitates the discontinuation process in collaboration with the client and family. And finally, the OTP ethically reports the outcomes to payers and referring entities when appropriate. And That's like the Cliff Notes version. But I think we ought to add in the role of the OTA.
For discontinuation.
Mhm.
Yeah, and I just looked up, they define the transition of movement from one life goal or experience to another, and like to prepare, facilitate a change from one functional level to another, one life stage to another, one program or one environment to another. So wanted to see how they define transition since they're using it in most of their stuff. So we need to include the assistance role in this. Do we feel like any of this is redundant? Do we need to keep it all, take anything out, like change the wording for A, like discontinue services when the client has achieved the goals or achieved maximum benefit?
I mean, that is the language that's in the AOTA. It's the OT is responsible for transitioning the client to another intensity of service or discontinuing service when the client has achieved identified goals, reached maximum benefit, or does not desire to continue services. That's probably a good one to add.
Yeah, I was gonna put that because a lot of times like in peds, like they just stop, like not much communication, like they just, the parents think they're done. So I feel like that would be an important thing to put in there. I think it said, or indicates a desire.
That's the way it's worded in the standards for AOTA, but we can change it if y'all don't like that.
Do you think it needs to say who does not desire continued services?
Or that they indicate that they don't want to, like. I just feel like that's different than like going into a setting where the patient like just doesn't want to do it that day. Which is why I stopped working with adults. I kind of want to do this today.
Yeah, well, that is different than a desire to have service discontinued.
Right.
Or maybe it's or requests discontinuation of services.
Yeah,
That's what
request
I was gonna
indicate.
say.
Happens all the time in peds.
Yeah, I know. So I'm kind of like, do we need to say something about like a caretaker? Does that happen like in the elderly population where maybe the family says?
Yeah, it could be if somebody's not cognitively or they have a power of attorney or something like that, then that other person can do that. I don't know that we have to specify that though.
Yeah, I don't want to get into the nitty gritty of that. I'm just making sure it covers all our bases.
Grammatically, Ingrid, would it be has requested? Because then client has achieved, client has achieved, client has requested.
Has requested, yeah. Thank you, Brenda. Oh, Kim, did you say something else earlier? Was it just a comment about the peds or?
Well, it was, yeah, I think that's clear. This helps clarify it about
Okay.
the
Okay, and then B, that we document a comparison of the initial and current state and deficits. So would that be more of like the discharge summary, or is this like, do y'all interpret this as like meaning like how we determine whether or not to discontinue?
No, that's really writing the discharge summary. So for the, hold on. She's responsible. Infamous. Then OT, the documentation piece is actually just discussed in the standards from the perspective of the OTA. An OTA contributes to the discontinuation plan by providing information and documentation to the OT related to the client's progress towards goals. And then the OT practitioner ethically reports outcomes to payers and referring entities, as well as relevant local, regional, and national databases when appropriate. So that's all the standards have in terms of documentation. They don't really have anything.
Well, I mean, it says that they prepare and implement a discontinuation plan.
Yes.
Like we
But
don't
in
really
terms of
say that.
comparing the patient's progress, they don't say what's in it. They do say the OTP ethically reports outcomes. That would be, you know, the outcomes would be the, I guess, the comparison of their initial and current state. Like, what is the outcome of this therapy?
Mhm. Yeah, I mean, we don't really say
The way
anything
they have it
here.
written out either to me. It could also just be occupational therapist shall report outcomes.
I mean, I think we could put that in C where it's like based on the, like whether they've achieved the identified goals, reach, you know, on the outcome, based on the outcomes of intervention. So the discharge plan consistent with the outcomes of intervention.
Where are you at?
I'm like wondering if like, if for B, just the documenting, like instead of like the comparison, just to use the wording that's more like based on outcomes.
Oh, okay.
And like, if it's something we can put in C, since C is really talking about the discharge plan. You know, like that the plan is basically based on the outcomes or the decision to discharge.
And should C come before B? Because you first they talking about the documenting in B, but then C is talking about preparing for discharge. Does that make sense?
Yeah, I kind of go back and forth with that too, but I think I'm stuck on like comparison of the initial and the current state, like, because I feel like you do that throughout the intervention process.
Mhm.
You want to just say outcomes,
Like in
both
C.
initial and current, or I don't know, that didn't really work.
I don't know if we technically need B because I feel like we covered that in like part of the plan, but then I understand that we need to include the outcomes in writing the discharge plan. So I think I'm just sort of trying to simplify it, but I don't know that we can.
Well, we have E, OTs shall document recommendations for follow-up. I mean, it could be OTs shall document outcomes of service provision and recommendations for follow-up.
Yeah, but I think it goes back to what Amy said of like B is sort of like preparing for the discharge plan. Like, is that how y'all take B? And then C is really talking about the plan is just being consistent with the team. And you consider the community resources.
I do think C comes before documentation, you know, that you're preparing a discharge plan, you're taking in your clients, the setting, the family, the other healthcare practitioners, and you're making a discharge plan. Then D, you're allowing sufficient time for that plan. You're not just dropping your patient like a hot potato. And then E, that you're going to document in some form or fashion the outcomes of your intervention and also your recommendations for follow-up.
Yeah, I'm just wondering if they put B because like once you compare the initial and the current, then you sort of making your decision like, okay, they're really not making progress. So then I'm gonna.
Yeah, we already covered that under the modification of the plan,
Right.
I think.
But that's why I was saying like the B, I feel like was already covered. But then we have to document the outcomes somewhere in the plan. So I was sort of thinking that we could get rid of B as long as we include some sort of documentation of outcomes.
I think we just add the outcomes to E.
I agree.
Yeah. Okay.
I have another comment about A whenever y'all are ready to discuss
Go
that.
for it. Go
Okay,
for it.
so sometimes I find with Medicaid and PEDS that insurance is no longer going to authorize regardless of our, justification. They're
Mhm.
just, so I don't know if that needs to be in there as another reason that we discontinue services.
Wow, that's a good one.
Payer no longer authorize.
Yeah, no, that is a good point. And how do we include that?
You just can't be accused of abandoning a patient because of money.
Right. But I mean, I feel like, it's our ethical obligation to document, right, Dr. Van, like if that happens, like that we document that that's the reason for it, or is that considered abandonment?
Well, you have to give them time to find all their alternatives. You just can't say, I'm done with you today because I can't treat you anymore, especially if it's a continuum of treatment, okay? And I'll use the area of that continuous treatment that I'm most familiar with, which is prenatal care. If somebody were to be dropped off of Medicaid in the middle of prenatal care, I have been advised by lawyers in the past that you have to continue the care, give them written notice that you're going to give them time to find another doctor, see them during that time until you've closed the time to find another doctor, and it all must be reasonable and it must be safe. Pat can weigh in if she has any other suggestions about the way you should do it, but that would be my concern.
Yeah, that all makes sense. It's just, if you just want to list that as among the reasons why there's a plan, I don't see any problem with that.
So like, I guess in like sort of, I think this is what Kim's referring to too. And like in our world, like if the insurance doesn't reauthorize services, and we discuss this with the parents and they're not able to pay out of pocket and they've applied for Medicaid and for some reason, they don't qualify. So at that point, the services are discontinued.
But again, if the services are needed
Exactly.
You just can't drop them immediately. You have to use a process that gives them time to find alternative care, and you provide care during that alternative time period.
A lot of
That's-
times it would mean we're developing a home program and teaching it to them and
Right.
continue to see them until they've learned the home program and or the family's learned it, which would be implied in letter D. Maybe it's not specified well enough.
Well, I think we just need to map that out with the time to find alternative care, because I'm pretty sure that's not occurring in the real world, like in some of these like pediatric clinics. And I mean, the home program is sort of like, I think we've mentioned it earlier, like I don't want people to think that that just only applies at discharge.
No, but I'm just saying that would be probably usually, certainly in the adult world, part of a discharge plan for a
Yeah.
patient.
Agree.
Being discharged before the therapist and the patient think they're ready, but it's because of the insurance situation. I don't know, it feels like a slippery slope to even go there about discharging because of insurance. I just don't feel like that should be in here.
I don't think it should. I mean, we all know it's a reality out there, and I think we need to make sure that we're, you know, like say we have like words that you have to have a plan before you discharge. But I think to say that that's one of the reasons that you consider discharge, I don't know that that's necessarily in the best interest of the public that we're here to protect.
I mean,
Yeah.
I feel like we're hesitant because we're protecting the practitioner. Not the
Well, that
patient.
too, yeah.
You know what I
It's
mean?
like
Like,
it's a real
ooh,
slippery
like,
slope.
You can't name that because that's not what people do. But to Dr. Van's point of like protecting the consumer, which is what our job is here, like I feel like the practitioners need to know that, like that you can't do that. And like, how does that work? Because one, I don't know that people are aware of that. And two, I don't know, like time to find alternative care and continue to provide services is, you know, that's not going to go over well. But again, our job is to protect the consumer. So if
Well,
ethically,
I mean, we already have it in here and under C that the consideration should be given to appropriate community resources for referral. So if they can't get paid, they can't get OT anymore, then the OT should be figuring, well, what's another viable option that's not OT, but you know.
right, like maybe more supported school or something like that. Yeah.
Do we need to have somewhere in there that the client needs to be notified in a timely manner or something? Because we're not before the discharge. Does that need to be in there?
Let's see.
Like read D, is that what you're talking about?
Yeah, under D, including.
But does that mean coordination with the client? Or is that just coordination with the team is the way I was reading it?
Oh, that's a good point.
Yeah.
Because we're not saying anywhere that the client needs to be notified ahead of time. That was my thinking.
Well, I think if C, it's like the discharge plan is like inconsistent with the client. So like hopefully C would make them part of the team decision. Like,
Oh yeah, I see that right here.
you know, like if it should be a team decision, right? So I guess it doesn't always happen that way, Amy. I understand what you're saying, but like if we're saying like we're preparing this plan that considers the client, the team, the family, and everything, then at that point they would be in it at that point. I mean, if you think we need to change the wording to make it clearer.
And something about the family and goals that doesn't read right.
Yeah, I agree with that.
Something's wrong there. I'm keep rereading it and can't figure out what it's supposed to be, but something's off.
I'm just trying some words here, Amy, based on what you were just saying. About including the client, occupational therapists shall collaborate with the client, allowing sufficient time for the coordination and effective implementation of the discharge plan. I was just trying to speak to like what you were talking about informing, and I just was thinking collaborate might be a better word.
Maybe so. It's better, I think.
Brenda, do you have thoughts on that family and goals comment? I get exactly what Amy's saying, but I can't put my
I'm
finger
one
on
with Amy that I've read it like 47 times now, and I don't know what's wrong with it, but something doesn't make sense about it.
That's consistent with the occupational therapy client, business, family.
I think they were trying to say that you consider everybody's goals
Yeah, I see that.
and expected outcomes.
I think it's like it's saying the team and the goals, like kind of separate. So like it's consistent with the client, the team, and the family, and the goals, and the expected goals and prognosis.
Because it should be consistent with the occupational therapist or not, or therapy, or I don't know, something's not right.
Or could we put family after client?
Family.
With the occupational therapy client. I'm gonna go back to standards of practice and see kind of how they word it.
Are they trying to say that we're preparing this discharge plan consistent with the goals of the therapist, the client, the family, and the team?
That's what I think it's trying to say,
I
that
think that's
we're meeting
what
everybody's goals.
consistent with the goals of occupational therapy client.
There you go. Just put the goals first.
Yeah, with the goals of the occupational therapy client, interdisciplinary team, and family, period.
Goals of
So
occupational.
with the goals of occupational therapy, the client, the family. And the interdisciplinary team. Period.
Oh wait, and the expected prognosis, where'd that come in? Oh, shall prepare a discharge plan that's consistent with the goals of all of this and the expected prognosis?
Do we need the expected?
Do we need,
prognosis?
yeah.
I don't think we need that.
In terms of adding in the OTA, I feel like here in E is where that would come in based on the standards. OTs shall document outcomes of service delivery and recommendations for follow-up. We can use this language if y'all like it. OTA contributes to the discontinuation plan by providing, or would that come earlier? By providing documentation to the OT related to the client's progress toward the goals.
For C, could it say the occupational therapist, in collaboration with the assistant? I mean, can you include them in that way?
Who are we, which letter are you on?
Well, I was just saying, like, can we put it in C where it says occupational therapist, in collaboration with the occupational therapy assistant shall prepare the discharge plan? Like, can we loop them in there?
Oh, yeah. Actually, I kind of like it, maybe right after this sentence, OT shall prepare the discharge plan. And then followed up with another sentence about OTA contributes to the discharge plan by providing information and documentation to the OT?
Well, I mean, yeah,
I mean,
I think that's
collaborate
very
with feels a little too loosey-goosey,
I don't think it's,
yeah.
Amy, put yourself on mute. Okay.
I don't think it sounds loosey-goosey to just put in collaboration with.
Yeah, because then I feel like it mentions them so that they would be part of it, but it's. Because I feel like just talking about them documenting is really just repetitive of earlier, of like what their role is in the plan, in the intervention.
I like that.
Okay, and I just want to throw out there for E, that would be the only time in this document so far that we mention the word reevaluation. Right?
Probably don't need reevaluation. It's recommendations for follow-up is really all it is.
Yeah, I just don't want to throw the word reeval in there when we've never used it before. I don't think. I'm trying to scroll back up and look, but I don't see it. I'm searching.
Can we just put a period after recommendation?
Instead of using for follow-up.
Okay, so the only time reevaluation mentioned is in the definitions, right here, and then in the supervision, sort of the next section. So I think we're okay taking it out.
And I think this is what, I think it was you, Ingrid, was just saying, like, I think just service delivery and recommendations,
Period.
period.
Well, that's true. This makes it, follow-up makes it sound like all you're doing is writing recommendations for like later, when really you're writing like what kind of DME you thought they needed. And
Right.
Well, in most discharge plans, we don't follow up after, right? I mean, so I think just.
yeah. Well, follow-up can include like you want them to get home health OT.
But I think that's included in recommendations.
Me too.
Right.
And it's broader because it would include DME and other things.
Right.
Yeah. Okay. All right, so let's just read back through it with the discontinuation, make sure everything sounds right. Discontinue services when the client has achieved the identified goals, has achieved maximum benefit from occupational therapy, or has requested discontinuation of services. And then the new B would be occupational therapist in collaboration with the occupational therapy assistant shall prepare a discharge plan that is consistent with the goals of occupational therapy, the client, the family, and the interdisciplinary team. Consideration should be given to appropriate community resources for referral and environmental factors or barriers that may need modification. Occupational therapist shall collaborate with the client, allowing sufficient time for the coordination and the effective implementation of the discharge plan. Occupational therapist shall document outcomes of service delivery and recommendation. So is E part of the plan, right?
Part of discontinuation of services.
But you would, when you're saying document outcomes of service delivery and recommendations, that's technically going to be in the discharge plan. I feel like that should go ahead, because then the last thing you would do would be allow time for the coordination of effective implementation of the plan. Or is that wrong?
No, I think the last thing you would wind up doing is documenting the outcomes of your service delivery and all the recommendations that you put into place Whether that was, you know, that all the time that you took to find them an alternative source of therapy, or teaching them a home program or whatever else, the last thing you do is wrap it up with your documentation.
That's separate than the discharge plan. So like your final note is kind of how you're picturing it in your mind. Dr. Van?
I'm sorry, I missed that. I apologize. You wanted to ask me what? I apologize. Had another phone call. Oh, my question. Okay.
Yeah,
My
I just saw
question
your
to
hand
you all.
up.
Oh, yeah, I'm sorry. My question to you all is, don't forget, we have an executive session that has to happen today. And we've already, at the 12 o'clock, you've been at this about 90 minutes. So I
Okay,
just
I'm
wanted,
sorry. I wasn't aware of an executive session.
yes, ma'am, we have an executive session on the agenda. So, you know, you all can go as long as you want.
We definitely would need to stop this then.
Yeah, let us just
But-
finish this section then. Thank you for bringing that to our attention.
Okay.
I do think the order is correct because, like we said, you know, sometimes insurance stops paying and you're going to document at the end that you've made every, just every opportunity to inform the patient that here are some other options, and you can document the timeline that you gave them and things like that.
Okay. And I guess too, you would also document like Ingrid was saying, like maybe they chose not to do that, but at least you documented that it was given to them. And
Yeah, very often they choose not to do it, but
yeah,
at least it covers I feel like us, as far as we're giving them every opportunity that we are not abandoning them.
okay. All right. That makes sense.
Ms. Darby, if I would observe, think about the concept of continuity of care. That's all I'm thinking about. You know, just understand that whatever you transition them to, make sure there's some continuity of care. So if it's going to be the home caregiver, if it's going to be a different caregiver who's going to, for example, they may say, well, I can't afford you, but I can afford somebody else. Just make sure there's a continuity of care.
Okay. Do y'all think that's worth documenting somewhere? Like, or do you feel like we're considering that?
Unless he thinks it needs to be more strengthened, we have it as consideration should be given to appropriate community resources for referral. That is.
So should we put at the end of C for continuity of care, or?
That's something I would recommend, but I think you have to decide what you want. Because I think the key, what you don't want to do is have a patient say, those people just left me in the lurch, you know? Because that's going to harm your reputation, it's going to harm the profession's reputation, and it's not going to protect the public. And look, I understand healthcare is a business and everybody has to be able to do it, but you still have an obligation to the patient, even when the business end is suffering.
Okay, well,
Ingrid, I was thinking maybe that phrase at the end of the sentence versus in the middle, because wouldn't environmental factors that could also assist with continuity of care?
Yeah, so instead of after referral, put it at the very end, barriers that may need modification for the continuity.
To
of
allow
care.
for continuity of care.
That's a good way to put it.
For the community resources for referral and environmental factors or barriers that may need modification to allow. that good? Okay. Okay.
Okay, I think we probably either need to decide to wait to vote on this until next time so that we can get into this executive session, or vote now. Or if we don't feel ready
Executive session should go rather quickly. It's only
Okay.
one item of business. I think you have time to vote on this and finish
Okay.
this section.
Yeah. So if we just want to kind of quickly like read through it, like basically achieve goals, maximum benefit, requested discontinuation. We included the assistant, prepared the discharge plan, considering the goals, the client, the family, and the team. And then we talked about community resources, home modifications for continuity of care, collaborate with the client, giving them time for coordination and the implementation of the discharge plan, and then document the outcome of service delivery and recommendation. So we don't mention the words home program, but I think it's really implied in C. I mean, I think it covers everything. Is everybody else okay with this section?
I am.
Okay. And someone motion to vote on this section as amended?
I move to accept this section as amended.
Okay, thank you, Brenda. I'll second it. Darby. All in favor, please say aye.
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 Anyone oppose? And anyone abstain? All right, any public comment on this section, Dr. Van?
One last check, and no, ma'am, there is none at this time.
Okay, so we will end it at
12:04.
yep, 12:04 with that, and we will move into executive session regarding a licensure matter.
Yes, ma'am. It's on the agenda. If you'll give me the opportunity to stream again, I'll go ahead and do that. If you would stop your stream, I'll stop your stream and get right back to mine. How's that?
Yeah, I see it on the bottom of the agenda now. My apologies.
No problem. So first thing we need to do
Dr. Van, is there a vote to go into executive session?
Yeah, we need a vote to go into executive session.
Okay,
Thank you.
a motion that we move into the executive session.
I'll second it.
Okay, all in favor?
Aye.
Aye. Anyone opposed? Abstain? So just a quick question, I guess, for Patricia. We do have members that are logged in, but that are not present.
Ask me again. I didn't understand that question.
As we move into executive session, I noticed that there are people who didn't reply, like Amy, Kelly, and Kim. So do we move into executive session without them?
Apply.
Well, you can't, I mean, you can.
I'm just letting you know, we still have a quorum, so.
Yeah, I'm assuming maybe if they didn't, I mean, I'm assuming any member that's present should be there. They should be moved over into executive session.
Okay,
We can move them over, and if they participate, they participate.
Right.
As long as you have a quorum.
Right. That's what I was trying to say. Yeah.
yeah, we do have a quorum. I checked it before we voted on the amendments to section 4917.
Okay, well
Did I
then,
not do something? Am I supposed to hit something I didn't?
Supposed to join this room 3.
I don't
I'm
see
joining,
that.
I'm moving everyone right now.
Oh,
Okay, I didn't get it yet. I just got it.
just give us some time. She's gonna move us all.
now I get it.
Tracy, can you hear me?
Yes.
I'm gonna leave you out in on the live stream, okay?
You gonna let me out? Okay.
Yeah. Amy, did I lose you?
Yes. I'm not, I don't know what happened.
Okay, I'm gonna move you back to the executive session just a
Like
moment.
I'm somewhere.
Just a second. Kelly, are you also having issues going to executive session?
Okay, I think that's everybody.
Looks like it.
Okay. So I'm going to make a motion on the matter of the waiver request under agenda item number 1, that the OT Advisory Committee recommends a letter of recommendation from the previous employer, grant a temporary license for 3 months with a pre-approved supervisor that would provide direct supervision 50% of the time for his weekly caseload.
And there must be a favorable report from the advisor. Do you want that?
Yes, I'm sorry, with a favorable report from the advisor.
And the permit will not be valid for work until the supervision agreement is in place.
Okay, correct.
One more piece that might have been missing is that the temporary license would last, or the supervision would last for 3 months.
That's correct.
Yeah. Okay. We
All
have
right, so
someone,
y'all need a second, I think.
someone to second it.
I will. This is Raylene.
Thank you, Raylene. All in favor of this recommendation, please say aye or wave a hand.
Aye.
Aye. Anyone opposed? Anyone abstain? Okay, and I guess we can't get public comment on that, so.
Hang on and I'll check. Give me a moment. No, ma'am, no public comment that I've seen.
Okay, do we have any further questions or comments for today? No? All right, the next meeting is scheduled for, is it March 10th? That's what pops into my head, but
Yes, ma'am.
okay, from March 10th, and we will officially adjourn this meeting at 12:38 then. Everyone have a great and safe Mardi Gras.
Thank you very much.
Yeah, thanks.
Yes,
you.
thank you all for your work.
Thank you.
Bye, everyone. Happy Mardi
Bye-bye
Gras.
and happy Mardi Gras.
Bye, have a Mardi Gras.